nomenclature has been changed from PCOS to PMOS. So adolescent PCOS or PMOs are talk of the town, even in the newspaper, media, and our young college girls. Increasing trend, we know that the incidence is increasing nowadays. This is Kolkata Times City reports a rise triggers polycystic ovaries in young women. Of course, we are all at risk for developing diabetes, being Asian and Indian. So among adolescent and young girls, PCOS prevalence is high now. As per Rotterdam criteria, it is 22.5%, and as per Androgen Access Society criteria, it is 10.7%, and in which non-obese are, that means thin PCOS are 71.8%. Most common phenotype is usually during adolescent, it's a mild PCOS. As per this Indian Endocrinology journal, the rural PCOS 7 to 19%. Even the gadgets are there in the rural, so the sedentary activity in the rural area also causing PCOS in our young girls. Urban, of course, it is high 16 to 48%. How do they present? Clinically, they have menstrual irregularities, androgen excess, overweight, type 2 diabetes, and infertility is rarely the issue during this adolescent PCOS. Normal puberty versus PCOS. This is a challenging for us. This situation, usually, normal puberty includes oligomenorrhea, amenorrhea, acne, and multicystic ovaries. But most of these symptoms overlap with the symptoms and signs of PCOS. So, especially if that girl is obese, weight gain causes insulin resistance leading to hyperinsulinemia. So that further stimulates hepatic SHBG and depression of that and increases IGF, leading to 5-alpha reductase activities in the ovaries and periphery. So testosterone convert into potent DHT and increased free androgens in these girls. So both hyperinsulinemia and androgenemia are more severe in adolescent PCOS in compared with general population. These are all the pathological pathophysiology. We know that during hyperinsulinemia, insulin receptor dysfunction happens at pancreatic level, leads to reduced SHBG, increased free androgens, and in the hypothalamo pituitary ovarian axis, increased LH, leading to stromal follicle and elevated androgens level. So hyperinsulinemia and hyperandrogenemia result in increased circulating free androgen levels, thus perpetuating the underlying pathophysiology of PCOS. How do we diagnose this PCOS in adolescent? We cannot label them as PCOS as per the general Rotterdam criteria. As per this ESTRAID guidelines, in adolescents, we need only these two. One is oligoanovulation or this menstrual irregularities and hyperandrogenism. These two are sufficient to diagnose PCOS. Ultrasound is not recommended for the diagnosis of adolescent PCOS. Why? Because in adolescents, they normally have functional ovarian cyst. That's a normal sonographic findings. We should not mislead. And maximum ovarian volume also occurs during this time. And we always do transabdominal. For young girls, we can't do TVS. So transabdominal sonography is inaccurate. And anovulatory and irregular periods occurs in 40% of girls in the early menarche time. So clinical evidence of androgen excess, acne, also common during puberty and resolves over time. So how do we diagnose? We have to look into hyperandrogenism. Clinical hyperandrogenism, majority of the girls will have mild acne, but moderate to severe inflammatory acne, that is more than 10 facial lesions in early puberty, is very uncommon. So that may be diagnosis of clinical hyperandrogenism. Coming to hirsutism, we can use modified Ferryman-Galway score with a level of more than 4 to 6 indicate hirsutism. But most of the time there will be self-treatment, threading and waxing and all those things may lead to limited clinical assessment. So clinical hyperandrogenism is not detected or doubtful, biochemical hyperandrogenism should be done by using the liquid chromatography and mass spectrometry methods. How do we diagnose biochemical hyperandrogenism? By free testosterone, free androgen index or bioavailable testosterone should be used to assess biochemical hyperandrogenism. DHAs provide limited additional information in the diagnosis. However, it could be considered if total or free testosterone are not elevated. Androstenedione is elevated in non-classical adrenal hyperplasia, and DHA is predominantly androgen, mild adrenal androgen or virilization or some kind of adrenal tumors, it may increase. So we have to rule out other causes of hyperandrogenism. So what precautions to be taken during diagnosis of PCOS in adolescents? Our aim is to diagnose early while preventing overdiagnosis of PCOS, and unnecessary treatment in otherwise healthy normal pubertal girls has to be prevented. And other disorders associated with irregular menses or hyperandrogenism must be excluded during the adolescence. So, presence of clinical features of androgen excess like hirsutism and biochemic hyperandrogenism in the absence of oligomenorrhea of more than 2 years is not diagnosed as PCOS but considered to be at risk of PCOS. So, adolescents at risk of PCOS means they have features of PCOS but do not meet the diagnostic criteria. The at-risk PCOS should be labeled, could be considered, and reassessment is advised at or before full reproductive maturity. That means the timing is at the 3 years post-menarche in relation to menstrual cycle irregularity, or at 8 years post-menarche in relation to the use of pelvic ultrasound to identify the polycystic ovarian morphology. So what investigation not recommended is ultrasound, because it should not be used for the diagnosis of PCOS less than 8 years of post-menarche due to high incidence of normal multifollicular ovaries at this stage. AMH, it's not a biomarker for diagnosis of PCOS in adolescents. It's not a good marker for metabolic factors and the lack of international standardization. But high cutoff value of AMH predicts this adolescent girl may develop PCOS in adulthood. It has got sensitivity, but good sensitivity, but low specificity. So its routine use in clinical practice currently is not recommended. So what are the testing has to be done to diagnose? TSH, prolactin, total and free testosterone, THEAs, 17OH, progesterone. Ultrasound of ovary is not essential if other two criteria are met. FSH, LH, E2 in amenorrheic adolescents can be done. Once PCOS has been confirmed, then you can do fasting and go over GTT, lipid profile and fasting insulin. So how do we manage the PCOS in adolescents? Mainly we need psychological support. As Dr. Mahesh told, there will be like Zenzi's are a lot of anxiety and depression, and we need to psychologically and mental support has to be given, especially when mother comes with a girl of irregular cycles with obesity, some kind of hirsutism. We cannot tell them that she has PCOS, lifetime management and no treatment, infertility, etc. We start telling, imagine the situation of the mother. So both the family and the girl has to be addressed psychologically, and treating the symptoms and treating insulin resistance, of course we have to do that. So it should be integrated, individual, comprehensive, scientifically designed, multifaceted approach to address all aspects of adolescent PCOS. So start from behavioral therapy, give a good exercise plan, nutritional and dietary plan, and addiction awareness plan has to be done in every college and school. We'll be talking about mobile banning and sedentary lifestyle to be avoided, physical activity has to be increased. All those things has to be addressed at this time. Rarely bariatric surgery is advisable here. So psychological intervention definitely need because of behavioral problems, abnormal eating patterns, damaged self-confidence due to hirsutism, acne and obesity, increased level of anxiety and depression. So all those things, first step in management of PCOS is psychological intervention. Lifestyle intervention, diet and exercise must be recommended. And even the weight loss of only 5% of total body weight is important, because it causes decreased insulin, LH levels, increased SHBG and decreased T2, so that improve the menstrual function, lower the testosterone levels, so that reduce hirsutism and acne. In future, it improves cardiovascular risk factors like blood pressure. So we have to treat the symptom. Concern of that girl has to be treated. Basically, it has abnormal uterine bleeding or cutaneous hyperandrogenism, obesity and insulin resistance. Treatment of AUP, there are a lot of medications. COS, I'm not going to talk much about it, next speaker will be speaking. So COS are the first choice for regulation of any pattern of menstrual irregularity, and we can add progestin because it's better, it inhibits endometrial proliferation, prevents hyperplasia and other risk of carcinoma in future. The estrogen component can be added, it reduces excess androgen, it corrects only the menstrual abnormalities, but it's prompt. To treatment of anemia, definitely with supplements can be given. How to choose these COCs? Suggested is 30 to 35 microgram of ethyl estradiol. If used less than 20 microgram, it may not be very effective. Progestin, you have to choose low androgenic activity or anti-androgenic activity like cyproterone acetate, rosperinone, domigestrol or dimegest. better to avoid high androgenic activity like norepinephrine and levonorgestrel in these adolescent PCOS. Is there any alternative to COCs? Yes, definitely. Progestins are available when COCs cannot be used, but it has to be given cyclically. Micronized progesterone 200 to 300 milligram or MPA 10 to 20 milligram, but it corrects only menstrual irregularities, not hyperandrogenism. So how do we address hyperandrogenism? Because most of the PCOS adolescent girls will have 50%, this kind of hirsutism. Local measures can be done. They'll only come with all faxing and laser and all those things they will ask. So apart from these local measures, we have to initiate hormonal therapy. I believe simultaneously we start doing, then the root cause will be addressed so that treatment will be better. So COS is managing hirsutism. Right progesterone is crucial. We have drospirenone and cyproterone acetate. Both can be used as a first-line management as per the Endocrine Society guidelines. Treating insulin resistance, of course, it's recommended. So first-line treatment for insulin resistance is diet and exercise. For patients with IGT, then metformin. For metabolic disorders, myoinositol can be added because combination of myoinositol and OCPs, enhances anti-androgenic effect, and the negative impact of OCPs on weight gain is balanced and metabolic profile is improved with combination of myoinositol and OCPs. So this myoinositol in adolescent PCOS has been associated with improvement of many metabolic parameters including glucose, C-peptide and insulin levels and HOMA-IR. So along with modest reduction in androgens and weight. So myoinositol can prevent developing of serious metabolic disturbances in adolescents in future. So this is a summary of management of PCOS in adolescents. First, you have to diagnose by the Rotterdam criteria. If the girl is overweight or obese, then you have to advise them at least, our goal is to reduce 5 to 10% of weight loss. Then followed by check the fasting glucose, insulin and lipids. If overweight, then perform OGTT. Then assess the symptom, treat the symptoms. If they have irregular menses, you will be starting OCPs or progestins. If hyperinsulinemia or acanthosis nigricans, any kind of IGT, then yes, consider metformin. If the girl is sexually active or start OCPs, then hirsutism or acne, consider OCPs, anti-androgens, topicals or other along with cosmetic measures. So to conclude, diagnosis of PCOS in adolescents is difficult due to overlap of clinical features with those of normal puberty. The diagnostic criteria applicable in adults are not the same for adolescent girls. So hyperandrogenemia and hyperinsulinemia may be the key features in PCOS with adolescents. So you have to do the workup of these patients must include, first we have to do tests for diagnosis, then tests to evaluate the other metabolic derangements, then tests to rule out other causes of hyperandrogenemia like thyroid and other adrenal tumors. So to conclude, treatment of PCOS includes treating the symptoms and treatment of insulin resistance. COCs, anti-androgens, metformin, myoinositol are part of the pharmacological armamentarium of PCOS in adolescents. Thank you so much.